Hello, I'm Art Papier. I'm an associate professor of dermatology at the University of Rochester and CEO of Visual DX. I have no pharma or industry support. My disclosure is shareholder and CEO of Visual DX. In this presentation, I'd like to pull together some broad themes about AI and clinical decision support and bring them together in kind of big picture musings here. Uh, in my career, I've been thinking about medical mistakes and medical errors, and a large problem that we've been focused on in our work is diagnostic errors. So we've used a iceberg as a metaphor, an analogy to think about healthcare quality and safety. Often people think about medication mistakes and surgical mistakes as the real problem in healthcare. But actually, the data supports that diagnostic error, cognitive mistakes, and clinical decision making leads to much harm. So, this iceberg is data from Improving Diagnosis in Healthcare, which is a report of the National Academy of Sciences in the US, where they're saying 74,000 Americans die each year from diagnostic errors. And it makes up a large part of decreased quality in healthcare in the US. And this is important, not really so much for thinking about how dermatologists diagnose, but thinking about how all patients are handled when they come in with a complaint on the skin. So, in the United States, 65% of skin problems and presentations are not presented to dermatologists. In other countries, it could be as 95, 99% of skin problems are seen by general practitioners, emergency physicians, and other specialists other than dermatologists because there's so few dermatologists. And research also shows that GPs are frequently wrong with their dermatologic diagnoses. So this plays out in some very serious ways. And this is a patient in a study that we ran years ago that had 3 hospital admissions in 6 months for the wrong diagnosis. So everybody who's a dermatologist in watching this presentation knows that this is probably was diagnosed as cellulitis, and the patient happened to have paniculitis and had 3 admissions for paniculitis treated with IV antibiotics. And so research in the US showed a 28% error rate in our study. Daniela Korshinsky's study and with colleagues at Mass General showed around 30%. A UK study published in the British Journal in 2011 showed 33%. There's a lot of admissions that are unnecessary that can lead to adverse events such as drug reactions or C. difficile. Clinical decision support is an opportunity to try to reduce error. And this equation is basically saying that the brain plus the computer based information is more powerful than the brain alone. And the point is not to say that computers are going to replace doctors, that it's a man versus machine argument. It's really an idea of augmented intelligence. And the point is that machine learning, which is a form of AI, is part of computer-based information that makes up clinical decision support. And clinical decision support doesn't have to have AI. It could have rule-based systems or Bayesian models, probabilistic models that are used to compute and make and help to improve decisions of diagnosis, testing, and treatment. So this is an image of the foundation of a massive skyscraper that's going to be built. And I'm going to argue in this presentation that medicine is like a massive skyscraper and it needs structure, information, and there needs to be homework done to lay the foundation for good data. So the skyscraper is data, and the data has to be organized and be really high quality if this skyscraper is going to stay upright. The next image is a map. It's a map of the Tokyo subway system, which is probably one of the most complex subway systems in the world. Maps help us get places. And what medicine needs is an organized map on the kind of foundation that will have medicine be accurate and highly reliable. So maps are something that Dr. Larry Weed was talking about over 50 years ago. So Dr. Weed invented the problem-oriented record and the SOAP note format. Subjective objective assessment plan was developed to aid thinking and to drive reliability. And what Dr. Weed said 50 years ago is that information structure drives reliability and frees the mind for higher level thinking. And this was really a profound statement, and it's why he went on to develop the problem-oriented record, the SOAP note format, to try to bring reliability to thinking. Unfortunately, the current state of the electronic record, at least in the US, is a bit of a disaster where we don't have a well-organized map and we don't have good data. But it doesn't mean that his message was wrong. His message, his North Star, was really highly organized data. So Dr. Weed was speaking to the idea that we just can't put too much information in the human brain. And he asserted that we could load to the brain data for a few variables. So thinking about the Wright brothers flying this plane years ago, 100 years ago, there wasn't a lot of data. They just looked to see which way the wind was blowing and they pushed the plane into the wind. But that's not the case for complex systems. If you're trying to fly this, you need more than your finger in the air to see the wind direction. You need computing. And if you're trying to handle the data that's in a modern ICU and in a complex medical environment, you need guidance systems. And so, what we're living through, all of us, is this transition from a memory based system to a more process oriented system. So, when I was in medical school many years ago, it was unaided decisions. We tried to put it all in our brain. Now we're trying to teach our residents and students about assisted decisions. And we have smartphones in the white coat that we can reach to and get data and get help on decisions. And when we model good behavior for our students and our residents, we're hopefully modeling information acquisition, not this idea of roundsmanship where the physician in the white coat was the all-knowing oracle. We're really trying to say there's humility and that we're going to model in training that we're going to look information up and we're going to share decision making with our patients. So when you step back and you think about, well, how do doctors solve problems? How do they clinically reason? A really important book in the field of clinical reasoning and diagnostic errors by a Nobel Prize winning economist, behavioral economist, Daniel Kahneman, called Thinking Fast and Slow. Highly recommend this book for anyone interested in clinical reasoning. And I'm going to give you a very, very quick version of it. He defined system one and system two. Malcolm Gladwell in the book Blink also talked about how experts can size up information in the blink of an eye. So you don't need to think about this equation and you don't need to think what this is. You just know that's the Eiffel Tower. And if you're a dermatologist and you see these burrows and you recognize those burrows, you immediately know it's scabies. So that's system one. It's the blink of an eye. Experts sizing something up in a second. So system one is automatic. And, these four images, herpetic Whitlow, granuloma annulare, upper right, stria, and zoster are just instantaneous pattern recognition for a dermatologist and will eventually be pretty much instantaneous for AI and machine learning. But system two is analytical and takes time. So in his book, Thinking Fast and Slow, Dr. Kahneman asked a Nobel Prize winning friend of his to compute this, and his friend had to stop walking to compute this. The brain couldn't think of the answer at the same time it's walking. And so if I said, what's the differential diagnosis for a 62-year-old with fever, end-stage renal disease on 10 medications, that also is system two. You have to think and use the analytical power of the cortex to have a differential. So not all images are system one. So these are four different patients with an exanthematous or morbilliform eruptions. And the answer to the diagnoses are not known until you know some history. Did the patient start a medication a week before the rash? Did they travel? Could they have Zika virus or chikungunya virus? You need to ask questions and add up the imagery with the questions to come to a conclusion of a differential diagnosis. So not all imagery is system one. Our brains are shifting back and forth between system one and system two, and cognitive mistakes are common. And these include things such as premature closure, or anchoring, overconfidence, and representative bias. And representative bias is the idea that you learn the classic and you're unaware of the variance. And this is a large problem in medicine. In a memory based system, we're asking the primary care doctors and the students to memorize the classic, and we're expecting them to generalize the variant when they don't have the expertise. So, clinical decision support is something that really can bring augmentation to decision making. And we recently partnered with the University of Maryland that implemented a randomized controlled study of placing a checker inside the Epic EHR workflow. And so the idea was that every time an ER physician went to admit a patient for cellulitis, they would get a best practice advisory in Epic, and it would ask them a series of questions. And one of the questions was, is it unilateral or bilateral? And they had a warning that if they clicked bilateral, it probably was not cellulitis. They'd enter the morphology, they'd answer some questions and get the differential. In this case, the differential shows stasis dermatitis first and other forms of dermatitis, not cellulitis. The study is currently being written up, but they had statistical significance for reducing unnecessary admissions to the hospital. They showed that they reduced unnecessary admissions by 38%. So this is an example of decision support, which is rule-based, where you're asking questions of a physician and you're trying to drive it into the workflow in the clinical environment. So what's the role of AI and how is it connected to decision support? Well, AI needs to be equitable. And this case is very, very subtle, the erythema on brown skin. And here is a targetoid lesion on white skin that's much more obvious. So both these cases are Lyme disease. And so when we think about AI, we have to be training on a great data set with imagery in all skin tones, light skin and dark skin. So these are matching pictures on the left of cellulitis with the erythema really subtle, and cellulitis and Lyme disease, and dyspigmentation and systemic lupus, and a very subtle exanthematous drug eruption. So to be equitable, we really need to work on collecting imagery and tagging imagery the right way. And so at Visual DX, we've been collecting images for over 20 years, and we put meta tags on the images that are not just the diagnosis. We're putting morphologic tags on images and using the Fitzpatrick scale to tag the images for skin type. And we're merging the machine learning that we do with the clinical decision support system. And so again, good machine learning requires good data. And so the composite on the right is just images of lupus, different presentations of lupus, showing the variation in presentation. And this is one of the things that machine learning can do that generalists have a hard time doing, is really training in thousands of images so that it can see the variance. On clinical practice, we've created an application that we call Derm Expert that's a component of Visual DX. And Dr. Brown, an ER physician, had a ER resident say he didn't know what this patient had. The patient came in and had a 3-week history of this growing very quickly. And they took a picture in the machine learning app, and on the second panel on the left, you see at the bottom, there's 3 icons: friable papule, skin ulcer, and skin erosion. So our take on machine learning is that machine learning should guide and teach. It shouldn't be just a black box. if you're not really sure that the machine learning is going to be accurate to the point of view that it's an FDA or CE approved device where you can make claims that the accuracy is so good it's better than a dermatologist. So when you're talking about hundreds of diagnoses, at least in the foreseeable future, there's too much complexity, there's too much ambiguity to say that we're going to give a percentage of a diagnosis to the end user. What we're trying to do with Visual DX and machine learning is augment the differential diagnosis and not use statistical probabilities to mislead the user, but to actually guide and teach the user in the process. So Dr. Brown said to me when he told me the story that the icon said friable papule. And he said to me, I've been doing emergency medicine for 30 years. I've never called a skin lesion a friable papule. But the icon looked like my patient, so I accepted it. I moved through the questions, and it gave me a differential. So we're using machine learning. We're exposing the non-dermatologists to the language of dermatology, and we're teaching them about skin morphologies. So we've been thinking a lot about equity in diagnosis over the years, and we've been collecting imagery for 20 years. And I wrote a paper in the Journal of the American Academy of Dermatology in 2006 called Disparities in Dermatologic Educational Resources. And we've been tagging these images, and we ended up with over close to 30% of the images are in skin of color. And we also realize the importance of this as for patient education. So when we survey our users, we're hearing stories about how important it is to show images that are contextual to patients themselves. So Visual DX is also used for patient education. And there's a workflow for the non-dermatologists where we created the icons that represent the morphologies in skin of color as well. We've partnered now with the New England Journal of Medicine and the Skin of Color Society on a project called Project Impact. This collaboration started over a year ago in a 4-part webinar series that's free on the internet that you can Google or find at projectimpact.org. That we had a 4-part series on bias and the skin. Project Impact was the inspiration of Dr. Nada Elbuluk, a dermatologist at the University of Southern California and the director of the Skin of Color Clinic there. Nada pushed us at Visual DX to do more, and we've set up a collaboration with the societies on the right. It's really a global effort to bring attention to the importance of good information and to drive better education and better care in skin of color. There are partner resources and events listed on the projectimpact.org that I think you'll find really useful in the research that's relevant to improving diagnosis. And we really, in patients of color, we really welcome collaboration with projectimpact.org. So there's Dr. Elbuluk's email address. Mine is papier@visualdx.com. projectimpact.org is listed. I thank you for your time. This talk really was trying to bring together the idea that AI is important. Incredible progress is being made in machine learning. We need good data. But AI is not a panacea. It's not going to fix all of medicine's problems. I encourage those listening or attending this conference to get involved in the broader field of medical informatics and clinical reasoning. There's a great organization called the Society to Improve Diagnosis in Medicine. I have a wonderful website. You can Google CITM, and you'll get to that website. And really what I'm speaking to this idea of clinical decision support and machine learning and AI and telemedicine need to come together to produce that reliable roadmap, that foundation to bring structure and high reliability to medicine. Without structure, without the roadmap, we'll just have more chaos in medicine. Thank you for your time and attention.